Good evening, everyone. Welcome to the INICET November 2025 recall session by Dr. Chandini from ADRPLEXUS. So now let's start with the questions and the discussion of the recent INICET exam which happened yesterday. I hope all of you would have done your exam well. So now coming to pediatrics, almost around 15 questions were from pediatrics. So out of those 15 questions from core pediatrics on the general pediatrics and the important things like your growth development, it was around 5 to 6. Whereas this time there was a more trend on the systemic side. So there were more questions from the systemic side, and those systemic questions were most of integrated questions with other subjects as well. So the question was from pediatrics and you had options from other subjects as well. So now let's quickly go on to the questions which has asked in the recent November INICET exam. Okay. Now looking at the first question, which among the following milestones is correctly matched with each? You're asking which is correct. Okay. So mature pincer grasp 9 months. No, it's wrong. Mature pincer grasp appears around 1 year of age. At 9 months, you see the immature pincer grasp. So that is a wrong option. Transfer object 6 months. That is correct. So transferring of object from one hand to another is 6 months. So that is correct. Next. Unidextrous. So unidextrous reach is something which happens around 6 months. Okay. So it's around 6 months, and bidextrous is around 4 months. So that is also wrong. Tower of 2 blocks. At what age they will be able to make a tower of 2 blocks? Yes. So tower of 2 blocks is even before 18 months. So around 15 months, they'll be able to make a tower of 2 blocks. Okay. So 2 years is when they are able to draw a vertical stroke and they can be able to make a tower of almost 6 blocks. So out of these 4, transferring of object by 6 months, that is the correct answer. Okay. So these are some of the other fine motors which we have discussed in class. So bidextrous reach is 4 months, unidextrous is 6 months, immature is 9 months, whereas mature pincer grasp is around 1 year. After which the other drawing images and copying images comes. Scribbling around 18 months, vertical stroke is 2 years, copying a circle is 3 years, cross is 4 years, rectangle comes around 4.5 years, and triangle is 5 years. Okay. So this is one question from the development aspect. Yeah. Now, moving on to the next question. An infant presents with progressive jaundice for 3 months, pale stools, high colored urine. Okay. So when this scenario is given, we all know that we are dealing with conjugate hyperbilirubinemia, which means some case of cholestatic jaundice in an infant. And they say that HIDA scan was done. So HIDA scan is done, which is done in case of obstructive jaundice and cholestasis, which shows no excretion. So when HIDA shows no excretion, it means that there is some obstruction. The most probable cause of obstruction in an infant is extrahepatic biliary atresia. That is going to be my diagnosis. So what am I going to do next? So that is what we are going to see. We'll go one by one. First one, breast milk jaundice. Stop for 2 weeks and give formula feed. So please remember, breast milk jaundice is because of a substance in breast milk which has beta-glucuronidase activity and which is going to deconjugate the bilirubin, in which condition you will have increased level of unconjugated bilirubin rather than cholestasis. Okay, so that is not going to be the answer. Galactosemia. So galactosemia can cause jaundice in infants and newborns, but they will give you other features of galactosemia like hepatomegaly, hypoglycemia, cataract, all these other features. That is not there. So we are not going for galactosemia. Metabolic condition, further genetic testing. Metabolic conditions are also possible like thyrosinemia and all, but other informations are lagging. Okay, here it is very clear in case of some obstruction and cholestasis. Okay, so what is the next step? It is liver biopsy. So as in the class we have discussed, this is the order which we are going to follow for investigating a case of EHPA. So ultrasound abdomen is done to differentiate from other causes. Next, I will go with HIDA scan. If HIDA scan shows excretion, I'm ruling out biliary atresia. But in this condition, there is no excretion. So there is a possibility of biliary atresia. The next test which I will do to confirm my diagnosis is liver biopsy, which will show fibrosis and proliferation of the duct. Okay. So here the correct answer, the best answer out of all these 4 would be liver biopsy. Right? Okay. Fine. And one more important thing, if you're going to treat as early as within 60 days, the surgery has to be done, which is Kasai's portoenterostomy. If that is not done, the next available modality of treatment is only liver transplantation. That is why extrahepatic biliary atresia is the most common cause of liver transplantation in children. Clear? Okay. Next question, another classic question, a topic which has been repeated so many times in the last 2 years, both in NEET-PG as well as INICET, which is nothing but DKA. Okay, so same kind of question, some twisted options were given. Okay, so now we'll go to this question. A sick child presented with abdominal pain brought to hospital with the following features. So some blood parameters were given. Here hyperglycemia was given and acidosis was given and potassium was in the normal range. Okay, so there is a feature of diabetic ketoacidosis, and abdominal pain is most of the time they present to you initially with abdominal pain. Okay, so in case of DKA, what is that we are going to do now? Bolus insulin. So we have discussed already in class, insulin bolus should never be given. Insulin should be given only as infusion. So ruled out. Next, normal saline 10 ml per kg for 20 to 30 minutes followed by insulin infusion, KCl 20 millimoles. Okay, so this somewhat is correct, but we'll see at the other options also. Third option, the same, but along with this sodium bicarb. So please remember, in case of DKA, once you correct the shock, dehydration, and the hyperglycemia, automatically a metabolic abnormality like acidosis also gets corrected. You don't have to give soda bicarb to separately correct the acidosis. So that is not the correct one. So we're just left with B and D. Here, the only difference in B and D is the amount of KCl which you're going to give. Whereas in B, they gave it as 20. In D, it is given as 40 millimole. So among this, the correct answer is D. Okay. So we'll discuss what we already studied in class. So when you have a case of diabetic ketoacidosis, you're going to see whether there is shock or not. If you have features of shock, A, B, C comes first, resuscitation. So you have to give a bolus of IV fluid, that is normal saline, as fast as possible. Then you'll come to the definitive treatment. If there is no shock, you'll go with normal saline 10 to 20 ml per kg over 20 to 30 minutes as given in this question. And to this, you will have potassium. Even though potassium is normal, here in case of decay, there is a risk of shift of potassium. So hyperkalemia is there. So you will add potassium and then continuous infusion. Okay. So continuous infusion of insulin, and insulin is never given as bolus. Okay. So if these four were the options which was given, this sounds better, right? Moving on to the next question. Okay, another question from GIT. Which among the following are seen in Hirschsprung's disease? Okay, they're calling, which is true regarding Hirschsprung's disease. Okay, failure of migration of ganglion cell. Yes, that is true. Failure to pass meconium after birth. Yes, in Hirschsprung, because of lack of ganglions, these babies will have delayed passage of meconium. Okay, so that is also true. Distal segment is dilated. Is it true or false? So here, if we see an Hirschsprung disease, you have a proximal segment which is dilated, which is the normal segment, and the distal segment which is constricted is the segment which is abnormal, which lacks the ganglions. Okay, so that is not true. Distal segment is constricted and it is not dilated. Non-coordinated peristalsis. Yes, that's true, right? So when you have a constriction where there's no ganglion, the peristalsis is not going to be coordinated to the next segment because it is constricted. Because of this, there's going to be stasis of feces in that segment, which is causing the megacolon. So that is also true. So multiple answer question 1, 2, and 4, all three are true. Whereas the distal segment is the constricted segment, which lacks the ganglions, and it's not the normal segment. Fine? Yes? Yeah. So A segment, which is the dilated segment, is the normal one, which has the ganglions. B segment, which is the constricted segment, lacks the ganglions. So this is with regards to Hirschsprung disease, which is one of the most common gut motility disorder in case of infants and newborns. Right? Okay. Next question. This is what I told about some kind of integrated question between pediatrics and pathology and other subjects. So criteria for nephrotic syndrome. So what is true regarding nephrotic syndrome? One, hyperlipidemia. Yes, hyperlipidemia is a feature of nephrotic. Proteinuria more than 3.5 gram per day, which corresponds to 3 plus 4 plus, right? So this is massive proteinuria. Okay. So yes, massive proteinuria is a feature of nephrotic. Hypoalbuminemia is also a feature of nephrotic. Whereas creatinine increase is not a classical feature in case of nephrotic syndrome in children. If it's going to be minimal change disease, your RFT functions is going to be normal. It's not going to be deranged. So 1, 2, and 3, all three can be features of nephrotic syndrome in children. Okay. Fine. Yes. So as we have discussed, it's also called as minimal change disease. So these are the important features, that is massive proteinuria, hypoalbuminemia, edema, which can even lead to anasarca, and hyperlipidemia. Okay, very classical features for nephrotic syndrome in children. You should not have hypertension, you should not have hematuria. If that is going to be there, then we are dealing with something else, which is not minimal change disease. Okay, fine. And the mainstay of treatment for nephrotic syndrome is going to be steroids, and you will have a tremendous response to oral steroids in case of minimal change disease. That's the classical feature of the minimal change disease. So answer is 1, 2, and 3. All three are true regarding case of nephrotic syndrome in children. And we also had another question similar to this. Okay, it was a scenario-based question. So we'll look at the scenario. A 5-year-old child presents with generalized edema. Urine analysis shows 3+ proteinuria, and 24-hour urine protein is also more. So here you can see there is anasarca, massive proteinuria. Okay, whenever there is anasarca with massive proteinuria in a child, my first diagnosis is going to be minimal change disease. Okay, but look at the next line. Kidney biopsy is showing segmental fibrosis and ilonosis, which is not a feature of minimal change disease. What feature we see in minimal change disease? Minimal change disease, name itself says minimal change, so you will have effacement of podocytes. You're not going to have these features. Okay, next, child shows poor response to steroids. Just now I told you that minimal change disease has an excellent response to steroids. Here there is poor response to steroids, so we are not dealing with minimal change disease. So what is that we are dealing with? Okay, so we have discussed in the class, when you have proteinuria, how to approach it. It's going to be mild to moderate proteinuria with hematuria, hypertension, edema, which is the classic post-infectious glomerulonephritis. In our case, it is massive proteinuria. So massive proteinuria, which is not having any other features like hematuria or hypertension, I will go with minimal change disease. In our question, it is clearly not minimal change disease, and the leftover diagnosis is FSGS. So my answer is focal segmental glomerulosclerosis. Okay, fine. Yes. So minimal change disease cannot be the answer. Just now we saw answer is actually focal segmental glomerulosclerosis, FSGS. Okay. IgA nephropathy. You all know that IgA nephropathy presents with hematuria, hypertension, and it's going to be like recurrent hematuria, which occurs after 1 days of pharyngitis or sore throat. That is going to be IgA. Whereas in biopsy, they will have mesangial deposits. Okay. Membranous glomerulopathy is not just so common like the other three conditions in case of children. So the correct answer is FSGS. Moving on to the next question. So this is a question from inborn errors of metabolism. A child presents with doll-like facies, hepatomegaly, acidosis, and anemia. Diagnosis shows that biopsy hepatocytes filled with glycogen. Okay, so glycogen is stored. So we are dealing with some kind of glycogen storage disorder, and directly they have given glucose 6 phosphatase is deficient. So glucose 6 phosphatase deficiency is a feature of type 1 glycogen storage disorder, which is nothing but Wojcicki disease. Okay, so it is directly given. So we are dealing with Wojcicki. The question is, which is the most common feature in Wojcicki? So coming here, fasting hypoglycemia is the very important and the earliest feature you see in Wojcicki. Okay. Next, cholesterol levels can be elevated because of acetyl-CoA, which is being produced excess. It can cause hypertriglyceridemia also. Lactate levels are not low, it is high. So you can have lactic acidosis. Okay, so among these, if the common and the most important is your fasting hypoglycemia. Okay, so this is what we have discussed already. So what is this? Glucose 6 phosphatase deficiency, which is going to convert glucose 6 phosphate into glucose. When this enzyme is not there, what is going to happen? There's no glucose. So what did I tell as the initial feature? Hypoglycemia was the first feature. Next, coming here, this accumulated glucose 6 phosphate enters the alternate pathways. It enters the HMP shunt pathway and produces hyperuricemia. It enters the glycolysis and produces pyruvate, and the end products or the byproducts of pyruvate, which you can see, are lactate. So you have lactic acidosis. Pyruvate can result to acetyl-CoA, which is the main substrate for production of triglycerides and fatty acids. Okay, so all these are features of Wojcicki disease. They will present with hepatomegaly, renomegaly, doll-like facies, and the treatment is cornstarch diet. Okay, it will prevent the episodes of hypoglycemia. Okay, fine. So the answer is fasting hypoglycemia for the Wojcicki disease. Moving on to the next question. A 10-year-old child presents with short stature, upper segment, lower segment ratio is 1.4 and no other systemic abnormalities on examination. What is the likely diagnosis? This was one exact question we also had in our rebound test and discussion session. Almost the same question and the same diagnosis. Okay, we look into it. Age of the child is 10 years. Okay, what is the normal upper segment, lower segment ratio for 10-year-old? The normal upper segment, lower segment ratio for 10-year-old is somewhere around 1:1. Okay. But here in this case, it is 1.4, which means that the upper segment, lower segment ratio is increased. Okay. When this ratio is increased, which part of the fraction is less? Which is the lower segment, which means the lower segment is short. So you're dealing with something which has short limbs. Among the options given, the one thing which has short limbs is nothing but achondroplasia. So achondroplasia is the likely diagnosis for this question. What about the other options? Spondyloepiphyseal dysplasia is where the trunk is involved. When the spine is involved and the trunk is involved, what happens to this ratio? The ratio will be decreased. Severe PEM, which is a chronic disease, and it can result in proportionate short stature. It will not have disproportionate short stature. The same with case of growth hormone deficiency, which is also an example of proportionate short stature. So here you can see that we have discussed the normal upper segment, lower segment ratio as per the age and the causes of increased ratio and decreased ratio. And what are the causes of proportionate? So growth hormone deficiency and any chronic disease will come under proportionate short stature. So by ruling out everything, we are left with achondroplasia. That is the answer for this question. Right? Yeah. So moving on to the next question. So another classical topic which has been repeated so many times. Okay. That is nothing but Gaucher's disease. So it was a multiple option question, which is true regarding Gaucher's disease was asked. So first option, crumbled tissue paper appearance, very important, true. Foam cell is not a feature of Gaucher disease. Okay. Okay, it is somewhat seen in case of Niemann-Pick or other things. Glucocerebrosidase deficiency, yes, that is also true. Sphingomyelinase defect, no, it is Niemann. Okay, so among this, crumpled tissue paper appearance and glucocerebrosidase, these two are true regarding Gaucher's disease. So coming to Gaucher's disease, this is the classical crumpled tissue appearance, so many times asked as image-based question also. Okay, so the child presents with developmental delay, pancytopenia, bone pains, and organomegaly. Okay, so X-ray can show Allen-Mayer flask deformity, all because of deficiency of the enzyme glucosidase or glucocerebrosidase. Now moving on to the next question. Okay, a boy with karyotype 46XY, deletion 15, chromosome deletion 15, presents with developmental delay, obesity, hypotonia, and hypogonadism. What is the likely diagnosis? So this is deletion 15 with some features. Deletion 15 is seen in two things, okay, which comes under genomic imprinting or uniparental disomy. What are they? Prader-Willi and Angelman. These are the two things. So either you are dealing with Angelman or Prader-Willi. It is not cry to chat or Fragile X. Why it is not cry to chat or Fragile X? Cry to chat is deletion 5p. And features like cat-like cry, that is going to be in cry to chat. Fragile X syndrome, it is actually a X-linked dominant condition, okay? X-linked dominant condition, which triplet repeat expansion. So what triplet repeats? You have triplet repeat expansion where they will present with macro orchidism, big jaw, large face, and low IQ. This is what is Fragile X. So we are ruling out cry to chat and Fragile X. We are left with Angelman and Prader-Willi, both of which can be seen in case of chromosome 15 deletion. Okay. Now, these features like obesity, hypotonia, and hypogonadism is a feature of Prader-Willi. Okay, so you can see we have almost the same exact question, which is in our Q bank. Okay, the features suggestive of Prader-Willi syndrome we have. What about Angelman? Angelman is also deletion 15, which is coming from the maternal chromosome deletion. Okay, Prader-Willi is paternal chromosome deletion. Angelman presents with happy puppet-like face, laughter-like episodes, low IQ. That is what is Angelman. Prader-Willi is obesity, hypogonadism. Okay. Yeah. Now, next question from rheumatic fever. We had two questions from rheumatic fever. One was directly a pediatrics question. Another was integrated question between pathology and pediatrics. We'll go one by one. First question, which of the following are components in Jones criteria? Minor, major, both was included. So it is a multiple option question. Carditis, yes, true, that is a feature of criteria. Erythema nodosum, no, it is not erythema nodosum. It is erythema marginatum. Okay. So erythema nodosum was given means it is wrong. Erythema marginatum is a feature of rheumatic fever. Polyarthralgia, yes. Polyarthralgia is also a feature. Chorea, yes. Short PR interval, no, it is long PR interval, prolonged PR interval. Okay. So if this was the option, carditis, polyarthralgia, and chorea will come as answers. Okay, fine. Yeah. So this is with regards to the revised Jones criteria. So here we have the major and the minor. With respect to the risk population, we have low risk and high risk. Okay. So the classical major things are carditis, arthritis. Okay. It can be polyarthritis, or in case of high risk population, you can have monoarthritis, polyarthritis, even polyarthralgia. Other features like chorea, erythema marginatum, subcutaneous nodules. Whereas in low risk, you have the polyarthralgia and monoarthralgia depending upon the risk category. Fever, ESR elevated, CRP elevated, and prolonged PR interval. It is not short PR interval. Okay? Yes. Now, moving on to the next question. Which among the following is true regarding rheumatic heart disease? As I told you, this is something which is integrated between pediatrics and pathology also. Ashkoff bodies, yes, it is what you will see in the HPE, which is very important pathology. So Ashkoff bodies is true pathology. Group B streptococcus, no, it is not group B streptococcus. What did we study? It is group A, beta hemolytic streptococci. Okay, so group A. So that is true. Group A is true, group B is false. So no. Myocarditis only, is it only myocarditis? In case of rheumatic fever, it is pancarditis. All three layers are involved. Okay, you can have pericarditis, you can have myocarditis, you can have endocarditis, which is nothing but your valve involvement. And aortic valve rupture. See, aortic valve rupture is not the main feature. The main feature in the acute rheumatic fever is the papillary muscle rupture, which can result in mitral regurgitation. So most common valve affected is going to be the mitral one, okay, in the acute period. So this is also not true. If single best answer is asked, Ashkoff bodies is true, all others are false. Okay, so that murmur which comes in the acute period is called as Carey-Coombs murmur. Okay. And the important feature associated with carditis is subcutaneous nodules. Now, moving on to the next question, which is a question from neonatology, a very important as well as a simple one, which most of you would have got it right. A baby term, mostly term, born by lower segment cesarean section, presents with respiratory distress. Chest X-ray image was not given. It was shown, it was given that bulging lung fissure was seen, and it resolved within 48 hours. Okay, so a classical scenario, a baby born by LSCS, distress, spontaneously or self-resolving in 24 to 48 hours, and X-ray showing bulging fissures, which is nothing but transient tachypnea of newborn. Okay, so TTN is the answer. So can this be respiratory distress syndrome? For this to be respiratory distress syndrome, first thing is the age group, gestational age. You should have a preterm baby, preferably before 34 weeks. So that is not there. Second, you cannot say all RDS will resolve within 48 hours. Third point, chest X-ray will show air bronchogram or ground glass opacities in the later stages. Okay, so that is not the answer. Meconium aspiration. Meconium aspiration will have patchy atelectasis. So that is not shown in given in the X-ray. So that is not there. Pneumonia. Pneumonia is another condition where you cannot say it spontaneously resolved in 48 hours. Okay, you will have other features of sepsis as well, because pneumonia is a manifestation of sepsis. So the correct answer is TTN. Why you have transient tachypnea of newborn? Because of delayed clearance of alveolar fluid. Okay, so they will present with mild to moderate distress. Chest X-ray will show perihilar streaks with fluid in the horizontal fissure. This is what they have given as bulge in the fissures. And here you can see there's an excellent prognosis. 24 to 48 hours they will resolve. Okay. Next question. From cardiovascular system, a child present with recurrent respiratory infection, acyanotic, bounding pulses, and the word continuous murmur in the infraclavicular area is given. So if the word continuous murmur is given in pediatrics, there's only one important diagnosis with regards to congenital acyanotic heart disease, which is nothing but patent ductus arteriosus. So a simple one here, it cannot be VSD, because VSD, what murmur we will have? In VSD, we will have pansystolic murmur. PSM. Okay. In ASD, you're going to have wide or fixed split. Okay, that word will be there. Wide fixed split, S2, along with ejection systolic murmur. Okay. PDA is where you're going to have these continuous murmur. Fine. Why there is continuous murmur? Because the pressure difference is present even during systole as well as diastole, and the blood is flowing from the aorta to the pulmonary artery in systole as well as diastole. So it's called as a continuous murmur. So with regards to PDA, so this is where the direction of flow is. Features are, they present in early infancy with features like congestive cardiac failure, failure to thrive, recurrent infections, and bounding pulses. Okay, so complications, they can result in infective endocarditis, Eisenmenger syndrome as well. And the peculiar feature with Eisenmenger syndrome and patent ductus arteriosus is differential cyanosis. Okay, fine. Next question from hematology. A patient presented with microcytic hypochromic anemia. Peripheral smear showed target cell. Okay, what is the next best investigation? With this picture, with target cell, we know the diagnosis is going to be thalassemia. Right. So it is thalassemia. If the best investigation of thalassemia was asked, I will go with either HPLC, or even after HPLC, I want confirmation, I can go with genetic studies like beta globin sequencing. This is going to be my order of preference. Okay, but both of which is not there in the option. Among the options given, we'll go with which is better. Bone marrow. See, bone marrow is not of any use in case of thalassemia. Okay, so bone marrow is not at all needed. Serum ferritin estimation. Serum ferritin can tell me an idea of the iron overload. I'm not going to diagnose thalassemia on serum ferritin. It can just give me an idea on the iron overload in case of repeated transfusion. Or if you are suspecting iron deficiency anemia, then you can go with serum ferritin levels. Okay. HP electrophoresis. Yes. In case of thalassemia, initially you can do HP electrophoresis, which can show you some features. Okay. Serum iron and TIBC, again, if you are suspecting iron deficiency anemia, go with serum iron and TIBC. Okay. So all other three options doesn't fit into thalassemia. The only option which somewhat fits into thalassemia is electrophoresis. Okay. If HPLC was there in the option, I would go with HPLC. Since that is not there, I'm going with electrophoresis. Right? Fine. So this is the peripheral smear of thalassemia. Here you can see the microcytic hypochromic RBC. And the target cells. All these are target cells. Okay. Now, here we have studied. If you do electrophoresis, what do you see in thalassemia major? HbA, adult hemoglobin is absent, and HbA, fetal hemoglobin is peaking. Okay, because the beta chain are not synthesized properly. Adult hemoglobin, which consists of alpha 2, beta 2, is not present. So it is absent, whereas the fetal hemoglobin is dominant. Fine. But the confirmative test is going to be HPLC followed by beta globin sequencing, still if you need confirmation. Treatment is going to be repeated blood transfusion, but the ideal treatment for cure is hematopoietic stem cell transplantation. That is the definitive treatment. Okay. So if you suspect iron overload, then you can go for studies like liver, cardiac MRI, or serum ferritin. Fine. So the better answer here would be electrophoresis because HPLC is not there in the answer. Right.